Good evening, everyone. My name is Kendel Christoff, and I am a registered dietitian, and I will be speaking about how to eat like a girl. So women do need a little bit different nutrition than men do. We have plenty of reasons. Our body composition is obviously different. We have puberty, childbearing years, and then of course menopause. So the body composition for women, we typically have less lean muscle and more fat than men, which means that we are going to absorb things a little bit differently. During puberty, the changes to our bodies will increase the nutrient needs, including things like iron, and it'll also increase our hunger cues. During the childbearing years, these will increase needs specific to fertility, pregnancy, and postpartum. And then menopause, where the body decreases in hormone production, and it will lead to changes in absorption and metabolism. So let's start with the teens. Feeding a teen girl. You really need to realize that teen girls are always hungry. They're always going to be looking for something to eat, and that's perfectly normal. Teenagers burn through a ton of energy. You want to start the nutrition behaviors at this stage in life because it can help them avoid problems later on in life that can lead to fad dieting and disorder relationships with foods. Teenagers are going to have higher needs, so you want to make sure that they're fueling their bodies for those needs, whether it's breathing, moving, focusing, talking, socializing, running, digesting, growing bones and muscles, developing. This is a really important time to make sure that they are not dieting and under eating. You want to actually feed that growth. Most teenagers should be eating every 4 hours. So we're looking at the calories. Normally not something I like to talk about. However, if we look at a number, it's going to be a moderately active teen needing about 2,000 calories per day. If they're athletes, that need will increase. It can be between 500 to 600 calories per meal, 3 meals a day, and 100 to 300 calorie snacks, at least 1 snack per day. I prefer it to be a little bit more though, especially for the busy teen. One of the things that we have to be very mindful of is that disordered eating is very common in teen girls. Teen girls experience a constant level of stressors that can lead to increased risk of developing eating disorders. It has actually increased 40% since the onset of COVID-19, and they need to understand the difference between healthy habits and dieting. There is no one perfect body type. All bodies can do amazing things. So be the example for the teen girl in your life and eat balanced regular meals and be kind to your body. Different things that you can do to prevent the disordered eating. Again, it's just making sure that you have healthy habits yourself and making sure that they have healthy habits as well. Making sure that the relationship with food is healthy so that they understand that there is no such thing as bad foods or good foods. It's just nutrition. All foods can fit in a healthy, balanced diet, and that does include things like ice cream and treats. You want to focus on the good. Nutrition is meant to keep you energized and growing, and this is the important time for that. And of course, again, set that good example. So looking at women, balancing your plate in womanhood could be very challenging. You have things like college, jobs, partnerships, and eventually perhaps children. This is when new hormones and new nutrition needs will develop. A balanced plate is going to include complex carbohydrates that are high in fiber. It's going to include lean protein, including plant-based proteins, healthy fats, iron-rich foods, and staying hydrated. We also have to look like things like PMS. It can increase your intake. You need to increase your intake of iron, zinc, and calcium. Fatty foods and sugar can be inflammatory and trigger bloating, no matter how delicious they may be at this point in time. And the same thing with salty foods. They can cause a little bit of water retention and bloating. So keep that in mind whenever you're looking at those snacks, that they might taste great, but they might not be nutritionally beneficial. Important nutrients you want to think about. Folic acid. This is especially important during pregnancy for fetal development. You want to look at B12. It's essential that all vegan and vegetarian diets contain a reliable source of B12, but then it's also extremely important during pregnancy for maintaining health of a new growing nervous system. Omega-3s, not only are they heart healthy, but they can also help prevent preterm birth. Vitamin D is pivotal to the absorption of calcium and maximizing that bone health, which can be very important later on. The stronger your bones are in young womanhood, the stronger they're going to be later in life. And then calcium, of course, is very important for maintaining strong bones and teeth. Iron is essential for the transport of oxygen in the body. It can help reduce that feeling of being tired and fatigued. And we often recommend that a lot of people, once you've hit that puberty stage, start to have your iron checked regularly to see if you are becoming deficient. It's an easy fix. And then, of course, you may need to take a multivitamin. Nobody's diet is going to be perfect. So this is a nice opportunity for somebody to make sure that they're hitting that optimal nutrition. One of the gold standards that we recommend is always going to be just the Happy Flintstones chewable with iron. Something else you'll want to keep in mind, skipping the fad diets. They're trendy and they're everywhere. They're on TV, they're on Facebook. Fad diets do not result in long-term weight loss because they do not promote healthy habits. So some of the things that they can cause, in addition to lack of weight loss, is going to be things like brain fog, irritability and moodiness, weakness and fatigue, low energy levels, and constant hunger. Look back at any diet you've ever done. Have you been the most cheerful, happy, full, satisfied person? Probably not. So we're gonna go ahead and skip the fad diets. During pregnancy, we wanna make sure that we're not just feeding mom, but we're feeding baby as well. So some of the things that you'll want to be mindful of is to stop smoking, eliminate alcohol and caffeine consumption, which can be associated with decreased fertility. You also wanna pay attention to your partner's diet as well. Weight gain is always going to be a key factor in pregnancy, but you also need to be mindful that calorie needs are not going to be as high as you may anticipate. During that first trimester alone, there actually is no increased calorie needs. So it's not really going to be eating for two as much as just adding a nice nutrient-dense snack. Food safety for mom and baby. Whenever you hear things like watching your cheeses that you're eating and watching the mercury, there's a reason for that. You wanna make sure that you're feeding everyone appropriately, but you also wanna watch how you're handling those foods. Proper temperatures are going to avoid those pathogens, so making sure that your fridge and freezer are at the right temperatures, cooking your foods thoroughly, and then keeping them warm if they need to stay warm or cold if they need to stay cold whenever you're having a party or serving things. Also, how you store foods is really important. Taking a look at your fridge. You don't want chicken sitting on top of the vegetable crisper. If it gets gooey and runny, then you have an entire drawer of veggies that are a salmonella risk. So just be mindful of that. And usually sanitize, as much as possible, sanitize your hands and the kitchen counters whenever you're cooking. Limiting foods that contain alcohol, mercury, and unpasteurized dairy is important. And then you can also add certain things to your diet by doing methods with cooking, using cast iron. Cast iron is a great way to help make sure that you're getting the iron in your diet. Consuming fortified drinks and cereal. Cereal is awesome. It usually is fortified with a lot of vitamins, nutrients, including iron and fiber. It's going to be very helpful and it tastes great. And then pairing vitamin C with those iron-rich foods. So if you're going to have something like spinach, make sure you have a little bit of strawberries or something in that nice salad so that you're absorbing that iron. And now we're looking at nutrition for the gracefully aging. Obviously, you're going to have some challenges during this point in life, including menopause, which is going to affect your ability to absorb and metabolize nutrients. You're also going to have lower calorie needs, so it can be really challenging because you may want to kind of stick to the diet you already have, but you might need to eat a little bit less. That's some of the things that you want to think about. The body does lose its ability to absorb vitamin D or digest lactose, so you might need to be on a vitamin at that point in time or some kind of enzyme to help you digest those things. And then your weight can shift from areas where they used to be to areas where you might not want them to be. So just keep that in mind as well. General health, you want to make sure you're taking calcium and vitamin D. This is going to be really important for bone growth, and you will also want to make sure you're getting those healthy fats. Fluids are really important during this age, and nobody seems to drink enough. So make sure you're staying hydrated. It's essential to almost all of the body functionings, from lubricating joints to pumping blood to the heart. Our kidneys also become less efficient during this time, so staying hydrated will help avoid infection. Other things that you could do to stay comfortable: limiting caffeine, alcohol, and spicy foods. These are things that can exacerbate hot flashes. So being really mindful how badly you really want to eat that spicy food whenever it comes that time. Increasing your phytoestrogen foods such as soy through soy milk or edamame, whole grains, oats, brown rice, barley, having that as a breakfast cereal, and then increasing those legumes like beans, peas, chickpeas, and hummus. Those are great snacks to have when you're entering menopause. So comfort during menopause, again, we're also going to want to try to eliminate some of that weight gain and bloating. So things that you can look into would be something like a probiotic, and that could be found in things like yogurts. Unfortunately, with as complex as women's nutrition can be, at some point, some women may have to start eating to survive. If you are being treated for breast cancer, your priority is to stay as healthy as you can during that treatment. A healthy diet can give you the strength you need to get through this process. Women are going to face a risk of malnutrition because they tend to eat less than their body needs due to changes in smell, taste, poor appetite, and discomfort. In addition to the poor intake, there's poor absorption due to the aging, diarrhea, nausea, or vomiting. Malnutrition can increase weakness and ability to fight infection and may cause delays in completing treatment. Calorie-dense foods are important for maintaining weight. Eating fortified foods, high-calorie soups and milkshakes, protein drinks, and calorie-dense snacks can be helpful. Being mindful of comfortable temperatures or textures, you may need it to be cooler or warmer than you would usually eat. Protein helps with maintaining lean muscle and recovery, and shakes or soft-cooked proteins can be helpful. Meeting fluid goals is also really important to avoid dehydration and infection during this time. Try to drink caffeine-free beverages. Warm drinks like herbal teas can be calming and very easy to tolerate. Take notice of the time of day you're hungriest. Make that your largest meal of the day. Continue physical activity to help you increase your appetite. The more you're moving, the hungrier you may be. If you're increasing your regular meals, it can be difficult. You could try small nutrient-dense snacks and meals. And if taste is really bothering you, make sure that you're brushing your teeth after every meal so that you don't have that aftertaste to put you off the foods you're trying to eat. And above all, food safety is crucial. Food poisoning can be dangerous to a weakened immune system and may lead to further malnutrition and dehydration. Wash your produce and follow the temperature recommendations, especially when heating leftovers. So some of the final thoughts, again, women's nutrition is complex at all ages. Women navigate staying balanced and hydrated, the complexity of hormones, the fluctuating needs, especially with calcium and vitamin D through the periods of life. In addition to that, 1 in 8 women will need to meet new challenges that are a result of breast cancer. With so many resources, please seek out a dietitian to determine what you as an individual woman might need so that you can benefit the most from your diet. Thank you very much. I would now like to introduce Kristyn Essad.
Hello, good afternoon. I'm Dr. Essad. I'm going to talk about primary care and women's health. Life is busy. There never seems to be enough time in the day, and women tend to focus on family, career, and taking care of others. While it can be difficult to put ourselves first, we can better care for those around us and handle life's challenges if we make time for self-care and make it a priority. Focusing on health and wellness is very important to your physical and emotional well-being. Primary care physicians play an essential role in health and wellness, offering personalized care in every stage of life. As we get older, we are at risk of developing certain conditions. Preventative care visits can help spot a health condition before it becomes serious. Asking your PCP the right questions at these visits will help address your health concerns. Understand your health status and recognize what you can do to improve or maintain it. Write down your questions ahead of time. Take notes and ask follow-up questions. It might sound difficult, but I have a lot of patients bring in a list with them and we go over that step by step. With preventative care, you are proactively managing your health. Being proactive means caring for your body before something goes wrong. Your physician will help you stay on track, letting you know what preventative exams, screening, or vaccinations you may need. And they differ with age. So in your 20s and 30s, you want to see your gynecologist every year. Ask if there's any immunizations that you may need, and review your family history and your mental health. In your 40s, talk to your personal doctor about screening mammograms. Consider blood work like cholesterol. I often do this earlier, especially if the patient has a family history of high cholesterol or someone having a heart attack at an early age. Discuss any changes in your body. In your 50s and 60s, you can talk to your doctor about colonoscopies. There's also an option now that we have, a Cologuard, which is actually indicated at the age of 45. And it's not actually a scope. You guys probably see the commercials on TV. It's easier a little bit than a colonoscopy. And then if that comes back wrong, you can just go ahead and get the colonoscopy if that comes back abnormal. Consider osteoporosis screening and check your hearing and your vision. And at all ages, we should all be eating healthy, exercising, and getting enough sleep, not smoke, and use the protective sunscreen or monitor changes. I also want to make a note that the wellness exam, we go over all of this. I have a lot of patients who seem to not really understand what a wellness exam is, and they're almost afraid or annoyed to schedule one. But actually, it's something that your insurance covers once a year. And on those visits, the doctor, like myself, we would just do your normal physical exam like we do the normal times you come in. But the medical assistant goes over all the injections that are needed. We go over things that you need, such as a living will, different screening tests that you haven't had. So it's very specific exam, and all the blood work that you order, your mammogram and things that you have done, they're covered by your insurance during those wellness exams. So it is a good opportunity that your insurance covers once a year. Breast Cancer Awareness Month. Although breast cancer is the second leading cause of cancer deaths in women in the United States, advancements in an increased use of cancer screening tests have contributed to decreasing breast cancer death rates. At Southwoods, we want to raise awareness about risk factors, the importance of detecting breast cancer early, and urge women in our community to get their annual mammograms. Certain breast cancer risk factors are unavoidable. You cannot control them. They include being a woman. The biggest risk factor for developing breast cancer is being a woman. 99% of new cases of breast cancer are found in women. Your age. After gender, age is the most influential risk factor. Over 70% of all breast cancers diagnosis are made in women who are 50 years or older. Family history. Women with a relative who has had breast cancer are at a higher risk of developing it themselves, especially if it's a first-degree female relative, mother, sister, or a daughter. Genetics. About 5 to 10% of breast cancers are thought to be hereditary, caused by an inherited gene mutations, BRCA1 and BRCA2, passed from parent to child. Personal history. If a woman has had already cancer in one breast, she is at increased risk of developing cancer in the other breast or a different part of the same breast. This risk is different from the risk of the original cancer coming back, which is called a recurrence. There are other risk factors that we can control. Choosing healthy lifestyle options can help ensure your breast cancer risk is as low as possible, and these include maintaining a healthy weight. Obese and overweight women have had a higher risk of being diagnosed with breast cancer compared to women who maintain a healthy weight, especially after menopause. Being overweight can also increase the risk of breast cancer coming back, again called a recurrence, in women who have had the disease. Staying physically active. Physical activity not only helps a woman reduce her risk by maintaining a healthy body weight, it may also have its own benefit to the risk reduction. Studies show physical activity throughout a woman's life reduces her risk independent of her weight. limiting alcohol consumption. Research has consistently found that women who consume at least 3 alcoholic drinks per day are at a higher risk of developing breast cancer than women who do not drink. Quitting smoking, again, smoking increases a person's risk of heart disease and lung cancer and is linked to higher risks of breast cancer in younger premenopausal women. The screening guidelines are as follows. Women between 40 and 44 have the option to start screening with a mammogram every year, and it's actually earlier than that if you do have a family history. Women 45 to 54 should get mammograms every year. Women 50 years or older can switch to a mammogram every other year, or they can choose to continue their annual screenings. This testing should be continued as long as the woman is in good health and is expected to live at least 10 more years. All women should understand what to expect when getting a mammogram for breast cancer screening, what the test can and cannot do. I do want to say that over COVID, it impacted a lot of women getting different testing, people going to the office in general. And I did find when people came in after not coming in for however long, more breast cancers. I mean, I personally can think of 4 off the top of my head, just of women who even skipped 1 year of their mammogram. So it is important to try to continue that, maintaining, being proactive, going for your wellness visits. And again, the questions will be at the end. Next is Dr. Barr. He's going to talk about the imaging technology. Thank you.
Thank you. So she went over a lot of the interesting things about breast cancer and screening, but I'd like to talk to you about the technology that we use to find breast cancer. So we offer the latest technology at Southwoods Imaging, and our results show that we really do an excellent job. So I want to go through each of the different techniques and explain why we use them, when we use them, and why we do some of the things that we do. So first is mammography. So this is basically the basic screening exam that we do. And we have advanced 3D mammography. It's sometimes called tomosynthesis. And it significantly increases the detection of breast cancer and decreases recall rates and false positive rates while offering the patient the most advanced, fastest exposure time, meaning we have you in compression less than in the past, and we have actually better images. And we also, and I think that Daryle may talk about this next, we look at all your risk factors and we actually tell you what your lifetime risk is in terms of what percentage of chance you have. And if that risk is greater than 20%, we recommend some additional tests like MRI to make sure that we don't miss anything and pick up cancers as soon as possible. And again, we have the latest technology with mammography, and we also have special compression plates that are designed so that they cause a lot less pressure and pain when we do this. We do compress your breast because the smaller we can make your breast, the better we get images. So we know that we are not being nice to you, but we have to, the more we squeeze, the better our images are, and this hopefully will make you feel a little bit more comfortable. We also have some pads that are like a cushion that we can use in women that are very sensitive. We don't use them on everyone, but if we know someone is very sensitive, we can use those pads. And again, the new technology is much, much faster, so we don't have you in compression very long. And this is one view of a typical mammogram, and you can see that the normal breast tissue is kind of white and the black stuff is fat. And what we do in the past, we did these 2 views, you know, one this way and one that way, so that we could see kind of like in a 3D area. But now we have something called tomosynthesis, and it's kind of like doing it like a CAT scan. If I could get this to play. And if you notice, the image is kind of getting a little bit blurry, but what we're doing, I'm going to try to play that again, is it's looking at the images and it's kind of taking slices. back and forth, and it kind of blurs things that are out of focus so we can see things. And again, this allows us to see smaller cancers. It allows us to maybe have a less recall rate, calling you back because we're not sure of something. And we do this basically on every case, and insurance is now paying for this because it does add a lot. And I think what we're noted for is ultrasound. We are a leader actually worldwide in ultrasound technology, and this is combined with a screening mammogram, and we actually sometimes can pick up cancers earlier with ultrasound than we can with mammography. And we do something special. It's called elastography. So with elastography, what we do is we look for tissues that are stiff. So breast cancers are stiff, they're hard, and this technology on ultrasound allows us to see how stiff things are. And if something is stiff in your breast, there's a very good chance that it's a cancer. And I'll show you some images, and I think I could train you with looking at those images to find cancers pretty quick. We'll talk about MR also. And again, we actually have pioneered elastography over the last several years. And we find that it's very, very helpful. And I'll give you some statistics about our lab. But ultrasound in general is something that we use quite a lot. So usually if we see something on a mammogram, we actually recommend doing an ultrasound because we can look at this a little bit differently. We can decide if it's malignant or not malignant. And we like to do our breast biopsies under ultrasound because it's a lot more convenient for you, and we can actually do a little bit better job in guiding the needle where we want to be. And again, this elastography is very, very helpful in us locating something, not only locating it, but also saying, is it a cancer or is it not a cancer? And this really helps us in stopping doing breast biopsies that we don't need to do. So we did a big study of several thousand patients, and thank you if you participated. When you have a dense breast, like I showed you that the breast tissue is white, well, cancers are white. So if you have a dense mammogram, we're looking for a white dot in a white background. So we often can't see this. So we really fail a lot when we're looking at these dense breasts to find small cancers because they have to get to a certain size before we can actually even recognize them, even with the tomography, although it's helped. And when we look at our study, we are average, maybe a little bit better than average in mammography. We pick up 6 to 7 cancers per 1,000. So if we do 1,000 mammograms, we only pick up 6 or 7 cancers. And that's around the national average of what we can do. But when we do this ultrasound screening after we do the mammography in those women that have dense breasts, we call them grade C or D breasts, we actually found an additional 3 to 3.5 per 1,000. So we find another 50% of cancers, and they're usually smaller because we can't find them in that dense breast. And what we're noticing now is those women that have dense breasts that are getting ultrasound and now coming back, and most of the OBs in town have women that we've picked up cancers that we would have missed on mammography and are really, I think, encouraging women to get the ultrasound. What we're finding is we're finding these cancers much earlier on the screening ultrasound than the mammography. So again, if you've got really dense breasts, ultrasound is a great option, and we're finding cancers that are 3 or 4 millimeters, so much smaller than a pea on this screening ultrasound. And with the elastography, it allows us to confirm that they're cancers. And again, we have 2 things to do. My job is to, number 1, find if there's something in the breast that doesn't belong, and number 2, to decide if it's a cancer or not. So it's detection and it's characterization. And again, we use the elastography as a very powerful tool for us to decide if something is benign or malignant. And again, when we look back before we had elastography about 20 years ago, if you look at the things we've published at that time, when we did a biopsy, we were like the national average that only 20% of the people we biopsied had a cancer. If you look at our more recent studies that we're using elastography, now we're up to 80%. So we're not doing a lot of biopsies on women because we can say that your lesion is benign and we don't need to do a biopsy. So we cancel a lot of biopsies that are referred to us from other centers because we can say with high confidence that the lesion is benign. And again, just to show you some of the things that I've talked about, again, you can see in this mammogram, which is very dense breast, it's all white, but here's an ultrasound and you can see most pathology, things that are abnormal in the breast are black and the glandular tissue is white. So here we can find, turns out to just be a simple cyst, but there's no way I could ever find it in this breast because we're looking for a white dot and a white dot. Here we're looking at a black dot in a white background. So it's much, much easier to do. And just to show you, this is a mammogram, and this is a fatty breast. It's mostly fat. It's black, if you will. And you'll notice that there's something here. These are little calcifications that I know from experience are benign. But we have this, and then what we'll do is we'll do an ultrasound. And here you can see this is that mass. And they have some specific features that we use on ultrasound. It's taller than wider. It has this white rim around it. We call it an echogenic halo. It has blood flow in it. When we can do this with our ultrasound, we can see that there's blood flow. And this bottom is the elastography. And what happens is if the lesion is stiff, it's red. This is telling me that we got a good exam. But you can see that the normal breast tissue here is blue. It's very soft. And I could teach you really quickly to see that if you see a big red dot, you know it's a cancer. So this has been really, really helpful for us in detecting things. And again, here's another case, a very dense breast. And when we did our screening, we found several lesions in that breast, but they were all blue. They were all very soft, and we could say that they were benign. We don't need to do anything else. The third method that we use is MR. We have 2-3 Tesla magnets, so the strongest magnet you can have. And this is really critical for breast imaging. If we have a 1.5 Tesla, which everybody else in town has, the strength is not good enough for us to really do good breast imaging. Unfortunately, we do have to give you a dye when we do this. And the dye really helps us because what the dye does is tell us how the blood flow is to a lesion, and we can tell from the way that the blood flow is going to that lesion if it's benign or malignant. And again, if you are very high risk, more than 20%, your insurance company will pay for an additional screening MR. It is the most sensitive. It finds the most things, but it's not very specific. So we find a lot of things. They may or may not be cancers. And then we usually end up doing an ultrasound to use that elastography to decide if it's something that we need to be worried about. And we use the MR for a couple things. One is initial staging of breast cancer. So if you did have a breast cancer, sometimes we like to do the MR because there's certain kinds of breast cancer that are like DCIS, ductal carcinoma in situ, or invasive lobular cancer, or cancers that we don't see very well, either on mammography or ultrasound. And what we like to do is make sure we do the MR because it allows us to see how big the lesion really is, so we can tell the surgeon how big of a sample he needs. And it's not uncommon for those two etiologies to actually have another cancer somewhere, either in one breast or the other breast. And in those, again, there's a high incidence of that. So we like to do this so we can decide exactly what your condition is so that you're treated right the first time and get the appropriate treatment. And again, we can use this for screening in those dense breast women, and we can again use it in those that we decide if a patient has a lesion that we know we may not be as good at deciding how bad the cancer is, how big the cancer is, or it's one of those ones that often has more than one in the breast. The other application is something called follow-up of neoadjuvant chemotherapy. So if a breast cancer is above 3 centimeters, or if it's certain types, so a triple negative cancer, there's certain cancers that do much better in your life expectancy if we treat you with chemotherapy first, as opposed to going to surgery first. And what we try to do then is shrink the tumor and before you go to surgery. And MR is excellent for us to follow that tumor because we can see it, we can see the blood flow. And if we get a good response from chemotherapy, we actually see the lesion getting smaller, and we see that there's no more blood flow to that lesion, and that tells us we're doing a good job. So here is an example of an MRI. And again, this is what it looks like. You can see the blood vessels because the contrast is in there. And here's this big lesion. There's actually another lesion here. And we did this because we had biopsied this lesion and it was a cancer. And again, here you can see we color code, the computer will color code the way the blood flow is. So cancers get a lot of blood flow, but then it kind of washes out. So it gets bright and then it gets dark. And what happens here, you can see, is there is actually another cancer in the other breast. So now we could go back and make sure, and again, we give you options, because if you've got bilateral breast cancer, it's up to you to decide. You may want to have a double mastectomy as opposed to bilateral lumpectomies. That's a choice between you and your surgeon as to what you need to do. And also, depending on what kind of cancers they are. And again, just to show you, this is MR is 3D. So this is that same cancer, but now looking at it from the side. The other one I showed you was from the top to the bottom. This is from the right to left. And here again, you can see this is an image showing you, again, this white stuff is the dye that we gave, so we can see this cancer. And again, what we can do is we can actually put a cursor, a dot on where we're looking at. And again, what happens is the cancers get a lot of blood flow in, and then they start to, we say, wash out. They lose color. Where benign lesions tend to not have a rapid uptake, they may be very slow, but they continue to go up. They don't have that drop off, if you will, of this. This kind of flags to us that it's a cancer. The other thing that I think that we do really well at Southwoods is breast biopsies. And again, if we find something that's abnormal, we do core biopsies. And I think we do an excellent job. Again, we try to do these under ultrasound because it's a little bit more comfortable for you, and we can do them a little bit quicker. You don't have to be in compression. And what we do is we do what we call core biopsy. So we take a little worm of tissue, and we take enough tissue so that we can do what's called markers. So the pathologist will not only tell us that it's a cancer, he will tell us, is it sensitive to estrogen? Is it sensitive to progesterone? Is it sensitive to something called HER2/neu? And knowing those features will allow us to determine what is the best chemotherapy and what is the best treatment plan for you. And like I said, the worst cancer used to be HER2/neu positive cancers. Now we have a chemotherapy that works specifically on those HER2/neu cancers, and it works very well. So now our biggest problem is what we call triple negative. All three of those markers are negative. Those tend to be the most aggressive cancers, the ones that we have a harder time treating. Now we do something called stereotactic biopsies. These are done under mammography, so you're in compression. We usually reserve this for calcifications. So in general, sometimes we can only see calcifications and we don't see a mass. And in that case, ultrasound is not very good. So these tend to be DCIS, ductal carcinoma in situ, so less aggressive cancers, but to biopsy them, we put you in mammography, and the machine is like a 3D machine, and it takes multiple images, and then it helps us guide the needle to the right spot. And then we can do those core biopsies again and get those calcifications, and we actually take a mammogram of what we take out while you're still there to make sure that we got those calcifications so that we did a good biopsy. So again, we do all these markers. There's another marker now that's called KR. And what that is, it's kind of how aggressive the cancer is going to be. So it's a marker that tells us, is this a cancer that's going to be really bad or really good? So this is also helpful in the oncologist and the surgeon helping with you to decide what is the most appropriate treatment. We also put a little marker, it's a little piece of surgical titanium when we do a biopsy, and we mark it so that if we have to go back to surgery, we know exactly where the cancer is, because sometimes it may be very small, we may not see it very well. Sometimes I take out almost the whole cancer if it's very small with the needle. And the other thing sometimes is if it's a big cancer and you get chemotherapy, the cancer may go away, but you still need to have surgery to make sure, and this will mark so we know where we need to do that. Daryle's going to come up next. She's our Nurse Navigator, and I think this is another really important feature about the Breast Care Center, because Daryle will walk you through this whole process and explain things to you, can get you hooked up. Our goal is that we diagnose you and get you actually everything done within a week. So you're not going to wait 3 months to see the surgeon. Daryle has the numbers to call and say, hey, you got to see this person tomorrow. And we make sure that if you need an MR, that we get you into the schedule right away. So we really want to progress you getting through all the things you need for appropriate treatment, and Daryle can talk about that when she comes up next. So if you look at our statistics from the Breast Care Center, we are in the top 10% of the country in terms of mammography outcomes. We use these things called PPV 1, 2, and 3. That's basically, are we finding the cancers? Are we calling them benign or malignant? Are we doing things appropriately? And again, we do very, very well. And our recall rate, when you have a mammogram, do we call you back because we want you to do another mammogram because we think there's something in there, we need to do stuff? Our recall rate is 2%. It's probably one of the lowest in the country. The national average is 11%. So we do really, really well, and we're not missing cancers, which is the important thing. And again, I mentioned that using the elastography and the techniques we have now, that we don't do a lot of biopsies that are negative. Almost all of our biopsies, 80%, are positive, so we don't have you do biopsies. Obviously, if we tell you, I like to say this, if you have a lesion and the chance is very small that this is something, we kind of give you the choice. If you want to have a biopsy because you can't sleep until your next mammogram, we'll do your biopsy. If you're scared to needles, we'll wait. So we work with you, and again, that's something that Daryle can explain to you, and we can work with you. So we really are doing a lot less biopsies, and to be honest with you, other places send us biopsies, and we often cancel a lot of them because we can confirm that there's no need for a biopsy. So with that, I'm going to end, and I'm going to go ahead and turn it over to Daryle. Again, she's our Nurse Navigator that really works with you to get you scheduled, make sure everything's done appropriately, and if you do have a cancer, to make sure you're getting all the tests as efficiently as possible. And again, if you kind of work with the Southwood surgeon, she can work with them to get you into their schedules very fast. Ideally, we would like to diagnose you and have you in surgery in a week and be done with this. And again, although we kind of have a breast center that's the surgeons are part of us. We have oncologists that are part of us, and Daryle is kind of the coordinator that makes sure everybody's talking to each other and make sure nothing falls through the cracks. So with that, we'll give you Daryle.
Hello, everybody. Let me put my glasses on. Lots of familiar faces. Prior to Southwood's Imaging Center opening in 2014, I spent the first 6 months researching best practice for our Nurse Navigator program. I knew the vision of Mr. Moransky had for the Center for Breast Health and knew exactly how I could use my experience to help women through a challenging and difficult breast cancer diagnosis. Like Dr. Barr said, we wanted to streamline the process so women can get the results and treatment as soon as possible. There's a picture of our center, our beautiful center. The focus when creating this program was and always will be the Southwoods way. That makes us truly different. The compassionate care, the attention to detail, perfecting the patient experience. Every single member of the Southwood staff is invested in this way of thinking. When you come in for a routine mammogram and you need to be returning for additional imaging, or you get that letter in the mail that says you need to come back in, that is a scary time, and it's a scary thing to have to face. Patients with possible cancer diagnosis have the opportunity to utilize us, Diane, my partner right down there, and Kaylin, who is on her honeymoon. We help get patients through this tough time. We provide education, information, and available to go over test results and actually get you through the tests. As soon as a suspicious mass or a lesion is seen, we are called in to speak with the patient. So we don't come in the middle of everything. We come in the beginning. It's often difficult for our patients, newly diagnosed, to properly evaluate all their care and treatment options, especially at a time when they are truly overwhelmed. We advocate on the patient's behalf and are available to answer any questions and concerns. We'll go over their images with them. Like Dr. Barr said, we'll review their pictures on their mammogram or their ultrasound. So educating and guiding patients and their families to understand their diagnosis and treatment options is really our goal. Helping them feel empowered so that they can make the right decisions, explaining the imaging and the path reports. Connecting patients with local support groups or counseling is, if they want, we're right on top of that. We'll help you get what you need. Food choices, physical activity, things like that that you need during treatment, that's all important also. We serve as a single point of contact, offering support and encouragement. We want to leave our patients with a very positive feeling. We're with them every step of the way. If we are with them during the biopsy and they have it with us, we try to be there before surgery also. So we'll follow them to the surgical center and we'll be with them right before surgery. We collaborate with physicians, surgeons, and radiologists to help set the course of treatment for each patient. Essentially, we are the link between the patient and the doctors that they need. Timing is very important to treatment. We guide the process in a way that provides timely and dependable results, helping reduce the time between screening result and a clear diagnosis and treatment plan. So, testing the national average. We have found that a screening mammogram to a diagnostic mammogram takes about 6 to 7 days. Diagnostic mammogram to a needle biopsy is another 6 days. And then a needle biopsy to surgery can take 14 days, and I've seen it take a lot longer. So you're looking at 27 days or maybe a month, could be 2 months if you need additional imaging. Or if you don't know who to go to and you have a discussion with your doctor, or you can't get in with your physician. But our goal is to streamline that process. The goal is to have all imaging done the same day if possible, along with the needle biopsy. So if we see something abnormal, we can perform testing that gets you to biopsy the same day. A patient comes in for a mammogram, our tech notices something, she tells the physician, we get them to ultrasound, we really see something suspicious, and that's when we're brought in. We go into the room, we tell them we see something, we can do a biopsy, we go through an explanation. Our doctors are right there willing to do the biopsy right at the same time, so they get 3 things done at once. And from surgical consult to possible biopsy within 2 weeks. And our surgeons keep blocks of time available so that we can get them in and they could get their surgery done. And really, it is done. We really do accomplish this goal. Compassion and kindness. Well, we know this is not as simple as it sounds. Breast cancer is devastating, and we help get through it. It is a tough time, but we are here for our women and men, and if you ever need us, you just have to call Southwoods. They'll connect you to the nurse's line. We have information that you need. We have pamphlets, brochures. We can go over everything. We could help you make the right decision. And we do, I really am proud to say we have really made a difference in the area. So Get your mammogram. That's the key. Thank you, everybody.